Orthopedic injuries. This will be a quick lecture of orthopedic injuries. The full orthopedic injuries lecture is already sitting on my YouTube channel for you. So if you feel like you need more than what we cover here, there's the full-length lecture there. I don't think you will really need it, but here we go. You know what the musculoskeletal system does, right? We don't need to spend time on that. You know anatomy by now, and you know why people are put together the way they are, and what different structures and organs in the body, what they do, and generally how they work. Musculoskeletal injuries, that's the reason that is the reason for more people seeking medical attention secondary to trauma than anything else. And we're talking everything from a sprained ankle to a fractured wrist. All of those musculoskeletal injuries are maybe a horrible back injury that leaves someone with a long-term disability that they'll never be the same again. That falls in that musculoskeletal trauma, and the reason for seeking medical care. You know the three different types of muscle. Mainly now we're talking about, in this chapter, we're talking about skeletal muscle or striated muscle, the muscle that does work. Smooth muscle is the muscle around your intestines and around your arteries, and then cardiac muscle is that specialized muscle that has automaticity and can take over and pace the heart. Skeletal muscles they're supplied with oxygenated blood from arteries, then veins carry away what's used up after perfusion, and the muscles are innervated by nerves. If you remember back to last week or earlier this week when we did the head and spinal trauma chapter, and we said that we have one motor nerve originating in the spinal cord. We have one motor nerve for each muscle that we have voluntary control over, right? That's okay. Skeletal muscles directly attached to bone by tendons. We have a picture here that is a decent illustration of that. That's not in your book. I dredged that up online. This is a biceps muscle, because it's bifurcated, and there are two muscles functioning together, but they have two different origins. Origin is the tendon attachment to it's like an anchor. Here we have, oh good Lord, I think that's the coracoid process. Sorry about that. Olecranon's out here. Coracoid process, that head of the biceps originates there with that tendon attachment to the bone. Then that tendon attaches to that bifurcation of the muscle, and then the insertion is the point where the tendon attaches to the bone that is to be moved. So muscles move joints by contracting. So the bending of the forearm, and then some of the rotation of the forearm come from the biceps. You can see the origin, there's the insertion, the two pieces, for want of a better term, of the bicep come down, and then they combine here in above the distal humerus, and attach to the radius. So that's the insertion, and that's how the work is done. We hadn't had a decent picture of that in anything else that we've talked about. I'll try to, for future semesters, copy that into those slideshows, because I thought that did a good job of demonstrating how that muscle is able to do work. You know what smooth muscle does. We're going to keep trucking. You know what cardiac muscle does. Muscles give our recognizable human form to us. Hopefully, a skeleton and a pro football player look a little bit different. Muscles are what give that football player his recognizable form, right? Muscles allow us to move. Blood cells, red blood cells, are produced in the bone marrow of the musculoskeletal system. I am not going to ask you how many bones there are in the human body, but it's 206. Pectoral girdle. Let's something we haven't talked a whole lot about. The scapula and the two clavicles make up the pectoral girdle. Think about a scapula. It is a spread out, large, flat bone, and it is extremely difficult to fracture. It takes considerable blunt force trauma to fracture that. So if it appears that our patient has a fractured scapula, we need to be concerned about intrathoracic trauma. We need to be evaluating for pneumothorax and any injuries possibly to the great vessels or even to the heart as we assess that patient. There's a picture that you've seen over and over and over. Let's add some anatomical names. The acromion process, you have the clavicle coming around, and then this portion of the scapula. So we have the big flat scapula, and then this bony prominence that comes off of that. That bony prominence is the acromion process. And then the glenoid fossa is the socket portion of the ball and socket joint that make up the shoulder. And then you have that humeral head, and there is cartilage between that for smooth gliding surface. It provides for rotational movement. It is a joint that can be dislocated, very painful dislocation. The labrium is like a little cup of ligamentous tissue that kind of cups that head of the humerus to keep the ball in the socket. And one of the long-term effects of anterior dislocation of the shoulder can be a torn labrum, and that can be repaired surgically, but don't know that it's ever really 100% after. Okay. Remember that your thumb counts as digit number 1, and then you have 2, 3, 4, 5 is your pinky finger. Those are phalanges. They're also called digits. They're also called fingers. So you may hear one doctor talk about the 5th finger and another one talk about the little finger. Or then you might have one talk about the 5th phalange. It's all the same thing. It's just however we're comfortable talking most of the time. Or you get old and lazy and forgetful like me, and you have trouble remembering tenderness, right? Metacarpals, those are the bones that make up the palm of your hand, and then your carpals are what most people call the wrist bones. And the distal end of the ulna, and then the distal end of the radius. The radius and those two carpal bones form a hinge type joint. Okay, the pelvis, it's a major structure. It's comprised of the ischium, the ilium, and the pubic bone. And you have, and there's one of those on each side. They articulate at the pubic symphysis, and then anteriorly, and they articulate posteriorly with the sacrum, and that forms the pelvic girdle. Fractures to the pelvis risk damage to the bladder, the rectum, and the internal female organs. Can cause considerable bleeding, and that pelvic cavity holds lots and lots of blood. We'll see that in a moment. Remember that the calcaneus is the heel bone. Fall from a height, landing on the feet, there's high risk of fracturing that calcaneus. And then picture up here that gastrocnemius calf muscle, and it's a strong muscle. And when that bone is fractured, that muscle is going to pull that tendon, and you're going to have a very shortened appearance to the gastrocnemius muscle, and it's going to be unbelievably painful right there in the heel, and then you can expect muscle spasms in your patient's gastrocnemius up there. Joints where two bones come together. There's a tough fibrous capsule that holds joints together. It's lubricated by synovial fluid. Anybody pop your knuckles? Pop your knuckles, that synovial fluid moving around in that joint as you pop it, and it expands the space, and that synovial fluid fills it up. At least I've been told that. Fractures can be caused by all of these things: direct blows, indirect blows, twisting forces, high energy forces. Can have high energy forces from automobile crashes, gunshot wounds, falls from a height that cause multiple fractures of multiple bones throughout the body. Strong bones require high energy for a fracture. It could be focused high energy that just nails one place, like that fall from a height that caused a calcaneus fracture. Slight force can fracture a bone that's weakened by a tumor, by infection, by osteoporosis. One of the ways that cancer involving a bone is found fairly frequently is through a pathologic fracture. That bone becomes weakened because of that tumor, and then maybe that person is walking, they just take a step, and their tibia fractures. Fractures breaking the continuity of bone. If there's not an opening to the outside, it's a closed fracture. If there's an opening to the outside, it's an open fracture. If there's a fracture with a laceration in the area of the fracture, we're going to treat that as if it's an open fracture, even though it might just be a laceration and a bone fracture. But there's no problem with treating that as an open fracture. You have a non-displaced fracture, think of a crack in a bone, or what's sometimes called a hairline fracture. The bone ends stay approximated, they stay in place, but there's a break. Displaced fracture moves outside of its normal structure. It provides a deformity or distortion. You can see that. I was describing a shortening of a fracture that resulted in some sort of shortening a minute ago that some people don't think about. But when that calcaneus is completely fractured and that gastrocnemius spasms up, then that causes a distortion of that part of the foot, and that kind of that classic shortening of that gastrocnemius. If your patient has a torn Achilles tendon, what is torn is muscle at the area where the tendon attaches to the muscle, And when there's a tear there, that gastrocnemius ceases to move the foot. And come to advanced trauma class, and I'll teach you how to assess that, but we're not going to do it now. I don't think there's any reason for you to worry about it yet. That would be an oblique fracture going across that angle there. That is a fractured tibia. That is a fractured proximal femur, but we call that a fractured hip, in quote, fractured hip. But all fractured hips are fractures of the proximal femur. What can't we use on that? We can't use a traction splint. Why? Because a traction splint is for an isolated mid-shaft femur fracture. Comminuted fractures, bone fractured into more than two fragments. Just think of a shattered bone kind of. The epiphysis, or the epiphyseal plate, is that growth plate at the distal end of a bone. Bones grow in children by building bone tissue on the bone ends, and a fracture into that growth plate can cause growth to stop. It can cause ossification or solidification of that bone end, and then the other end will grow, but that involved end won't grow. Green stick fracture is an incomplete fracture. The periosteum is the outside layer that goes over the bone surface. And incomplete fracture, it's just like grabbing a tree branch that's small and a green one that's still alive, and you break it, and if you get it to break down on the bottom end, there's going to be a part that stays together. That's kind of what a green stick fracture does, and the periosteum helps hold that together. Incomplete doesn't go all the way through the bone. Oblique, it goes at an angle like I showed you. I've described pathologic as weakened or diseased bone. A spiral fracture, rotating forces that cause a fracture can cause a spiral fracture from that twisting force that just, think of a candy cane at Christmas and that red that spirals up through the white, and you could just picture that maybe being a spiral fracture. So it gives you some sort of mental image until the day that you see an x-ray of it. Transverse goes straight across. It breaks perpendicular to the bone. Some pictures. So what do we see here? This, to me, what bones are right there? It's tibia and fibula. We see deformity. We can't see tenderness, and we cannot ask this patient, does it hurt when I poke here? We're not going to see them wince in pain and pull away when we touch that area to assess it. So we can't assess guarding in this picture, but what can we see? We can see deformity there. We can see some swelling there. How do we know? We compare one leg with the other. Well, they're not always exactly the same, are they? No, but we don't have anything else to work off of. So we're going to compare sides. What do we see here? We see swelling and a little bit of discoloration in this patient's right knee. The left appears to be a pretty normal knee. So see some discoloration, some bruising in that ankle. That looks painful to me. Crepitus, you feel like the bone ends crunching, kind of. It feels like you imagine it would. False motion. Let's see. If this guy tried to flex his knee and his ankle together, and he tried to, so dorsal flexion, he moves his toes toward his head, flex the knee, bends the knee. This one could bend, have a crazy bend at the site of that fracture. So when muscles contract to help to do work on the bone, that false motion would be that movement at that fracture site. Exposed fragments of course. Patient history is how we're going to determine a dislocation if it has reduced itself, which is fairly common, especially with patellas. They tend to that happens in adolescent athletes a lot. Athletes, that doesn't have three syllables, does it, buddy? In adolescent athletes, you with a kind of if their foot's planted and they turn or cut and the upper leg moves, that can displace or dislocate the patella laterally almost every time. When they straighten their leg back out, that pops back in place, but it's a very painful injury. If a dislocation doesn't reduce itself, it is a serious problem requiring quick intervention because it can interfere with circulation, can damage nerves, and we don't want that to happen. Signs and symptoms of dislocation: marked deformity. If it remains dislocated and it hasn't reduced, it's not going to look right for that patella to be on the lateral side of the knee and their leg not to be in alignment. So you can expect to see swelling in that joint. Movement aggravates it considerably, but enough movement, if that causes the dislocation to reduce, then there's a major pain relief then. The only time we're going to try to reduce anything, fracture or anything else, is if we have no palpable pulse, we have a cool, pale extremity and contact medical control, they might not or may not let you attempt. If they do, we make one attempt and we rapid transport. We don't try over and over. That causes more and more damage, and we're killing time on the scene. Time is tissue, right? Tissue that isn't perfused dies. Lose loss of normal joint motion. Could have numbness or impaired circulation in the area. Paresthesia, pins and needles feeling. Okay. Knees, shoulders, ankles, wrists. Those are very susceptible to being sprained. Tend to look kind of like that. Guarding, don't touch it. Ouch. Swelling and ecchymosis, pain, and possibly instability of the joint. You may not be able to distinguish between a non-displaced fracture and a sprain. Document the MOI, treat it as a non-displaced fracture. The treatment's the same. We're going to use RICEs on it. Rest, ice, compression, elevation, and splinting. RICEs, that's our acronym. Strain, that's just stretching of a muscle that tears muscle fibers. It causes pain, causes swelling, can cause bruising, should not cause deformity. We treat it with RICEs. Okay, amputation. This is more of an avulsion, I would say. That's just a flap of tissue severed from that thumb. I guess some would call that an amputation. I found this picture this morning. That looks more like an amputation to me. You have pale, it even looks cool. It looks like room temperature. You have 4 pale fingers that are slightly flexed. I mean, flexed. Yeah, slightly flexed because the tendons have been severed. And this is after reattachment. So see the color difference? That's an amazing bit of surgical work there. You can amputate legs, you can amputate hands, you can amputate fingers and toes and arms, legs. How do we treat those things? We'll see in just a minute. Okay, open fracture, irrigate it. Don't put your hands in there and brush it. I don't think. Your book says yes, so that could be an answer if that's all you have on an exam. Use sterile saline, irrigate that, get all the funcola out of there that you can with the sterile saline, wash away the dirt, the grime, all of that stuff the best you can. Don't touch those bone ends. Don't poke around in there with your finger. We're going to put bulky dressing over the end of the stump. And if there's massive bleeding and a lot of times with the amputation, it doesn't bleed as much as you'd think because those severed veins and arteries contract naturally when they're cut, and that tamponades that vessel or squeezes it down together so it doesn't bleed as much. That's not universally true. Sometimes you see massive bleeding, you treat that with a tourniquet. So we always want to prevent further injury. Try to reduce wound infection. That's hence the irrigation with sterile saline and not poking our fingers around in that torn up tissue. Use, in our world, it's not going to be ice, real ice. It's going to be a chemical cold pack. Call ALS for analgesia is pain control. Call ALS to give some pain meds. Prop transport. With amputated parts, there's a golden hour there also. The more time passes from the event, the less likely there will be successful reattachment, because you have to reestablish, you have to reconnect veins and arteries so that you reestablish perfusion to that amputated part, whatever it was. So we need to beat feet there. Don't get caught missing massive trauma to your patient and having a critical patient who has an amputated finger, and you're crawling around in a wrecked car looking for an amputated finger or two for 45 minutes. You may have just killed your patient. That platinum 10 still applies. You could always call for additional resources to hunt for the amputated pieces while you go ahead and transport the patient and instruct them on what to do to bring it right behind you. If they're EMT firefighters, paramedic firefighters, another ambulance crew, they're going to know what to do with it. Keep yourself safe. Additional resources I just mentioned. I mentioned 3 of them, actually: law enforcement, advanced life support, additional ambulances. Let's add fire in there. All the first responder family. We don't want to hurt anybody's feelings. Okay. And our number one is we're identifying and managing life threats. Like I said at the beginning of the lecture on abdominal trauma today, these can be distracting injuries. I have known of people who let a patient decompensate on scene while they were looking for an amputated finger or an amputated ear. Or don't do that. You cannot do that. Usually with these isolated orthopedic injuries, we're not going to have airway and breathing problems unless our patient, maybe our patient's an asthmatic and the stress of that situation triggers an asthma attack. Can we treat that? Yeah, you learned how to use those beta 1 adrenergics to open up the bronchi, right? Yeah, you know how to do all that stuff now. If there's any problem with airway breathing, it's rapid transport. Like I said before, the backboard is a splint, or securing your patient's legs to your stretcher. Those are a splint. If you have a critical patient, don't ever be caught messing around on scene trying to do a bunch of pretty bandaging and splinting. Just treat those life threats and go. If you can, get a sample history, get a good, and this is a time that we're with orthopedic injuries that we're really going to hammer on that OPQ RST. Of course, we use DCAT BTLS to assess. Here's something new that we're adding. We're going to, now you already know how to do motor, sensory, and circulatory assessment. So we're going to just like you did in lab when we splinted fractures and dislocations. You know how to do this, and you know how to assess motor, sensory, and circulatory. You know when to do it. Musculoskeletal assessment also includes asking questions about the 6 Ps. Pain, this is in a different order than I memorized it, so I'm going to read it. Pain, paralysis, paresthesias, that's numbness and tingling, pulselessness, pallor, being pale, and pressure. Okay. Splint all your fractures, dislocations before moving your patient unless they're in immediate danger or they have a life threat that you need to treat right now and you need to get off scene and headed toward a surgeon. Then we don't stay around and do that stuff. Splinting, what does it do? It reduces pain, it makes it easier to move the patient around, and it decreases the risk of those fractured bone ends causing additional trauma to the associated structures. You can't treat it if you can't see it. So we're going to cut pant legs away, cut arms of shirts away, cut heavy leather boots off if we suspect a fracture, so we can get down here and see it and treat it. Unless you can palpate that dorsalis pedis pulse to assess motor, sensory, and circulatory in that extremity that appears to be fractured, you're not assessing and treating that patient. So the boot or the shoe has to go in in a manner that has the least risk of additional trauma to the patient, provides access right now. I'm talking trauma shears, right? You start cutting somebody's expensive motorcycle boots off and they're not happy, but they'll just have to be unhappy, or their cowboy boots. Try to cut along a seam. They might be able to sew it back together. It won't ever look 100%, but it might function. Okay. Pad all splints. When in doubt, splint it. Splint it in the position of deformity unless you don't have a pulse and you have an order to attempt to reduce that fracture. So you're going to take gauze and you're going to pad under any voids in that splint, just like you did in lab. Remember, if you're using an air splint, well, you don't really have to. In the air medical world, if there's an air splint and you climb out to altitude, whether it's in a helicopter or an airplane, you have to check the inflation of that air splint. And then as you descend, you're going to have to add air back. You have to take air off. I mean, you have to add air as you ascend and take air off as you descend. Okay. Traction splint, you know how to use and when to use it. Pelvic binder, we talked about in lab. It's for temporary stabilization to try to avoid that bone end puncturing the bladder or lacerating femoral artery or the femoral vein. Those will bleed out fast, and you will take an injured patient and make a critical patient out of them and make a dead patient out of them if you spend too much time messing around. Your book says you have about an hour to manage that pulseless limb where you've lost pulses from a fracture. So part of your assessment is assessing in your mind what the length of time of transport is. So we may be calling a helicopter, or we may be expediting our ground transport. The straight up fractures in your book, I'm going to blast right on through. Dislocated shoulders, that humeral head normally dislocates anteriorly. Very painful. It's tough to stabilize it. That's how we do it. That's painful. It's going to hurt them to put their arm down on their chest. So what do? We put a pillow or a blanket in there and pad between and keep it more in the position that it's in when we find them. And then we use the sling and swath to stabilize that, transport them in a sitting position, unless you're worried about a spinal fracture. We're about to hit 11:30. I'll keep going, and you guys are free to go or watch this later, or you can hang with me and let me finish, whatever you want to do. Okay. That shoulder joint is, for the most part, going to be locked. They're not going to want to move their arm. May have numbness in their hand. Their hand may feel cool to the touch. That's going to be because of pressure on the brachial artery coming down, most likely. Fractured humerus. If it's a midshaft humerus, we don't have to put a splint up there on the upper arm. We put a sling around their wrist, swath that to their chest, which holds their arm to their chest. They may already be in that position when we find them. They may already be splinting that thing and holding on for dear life, holding it against their chest. And if we determine that's the only thing wrong with them, then we can just get a sling on there, swath that to them, and then we have managed that. Go ahead and apply some ice to that fracture site. That will help with pain and swelling. Fracture dislocation of the distal humerus, call that a nursemaid's fracture, happens fairly often in little kids. Somebody will grab them by the arm to pick them up and move them somewhere. Sometimes it happens, child abuse, they grab them by the arm and jerk them up. Sometimes it's just mom or dad playing with the kid and they grab them by the arm to help them jump higher, to jump up on an ottoman or a chair, or jump up over a curb, and you get that fracture dislocation of the distal humerus. Very painful, as is this elbow dislocation. So how do we treat those? That nursemaid's fracture, we're going to splint the joint above, the joint below. We're going to immobilize that. We're going to put ice on it. We're going to transport it. That's the best we can do. Same with that one. That sucker would be hard to, that's a gymnast. That would be hard to reduce for me, I think. You give it one shot if you get an order from the doctor. Otherwise, we have to figure out how to transport him with his arm in that position. Well, that arm's bumping up against the cabinets on the driver's side of the ambulance. You may have to transport him with his head toward the foot of the stretcher. Then you can't elevate his head, but at least you could try to splint that arm and it won't be banging over against the cabinet. You have to lock your cot in. So whatever that device is, and where that puts you in proximity to the wall, you've got to roll with that. Electron process, that's that knob on your elbow, and usually that's more of a fracture from direct force, a lot of times from a fall, and just popping that electron process off. Really painful. Put ice on it, immobilize it, and transport them. That's the best you can do. Or call ALS to give them some pain meds. The treatment's the same, other than you have a different color patch on your sleeve and you can give them pain meds. Okay. Radial head, fall on an outstretched arm. Also, fall on an outstretched arm can cause shoulder dislocation. That's a lot of times the mechanism of injury for shoulders. Every time it says assess distal neurovascular function, that's motor, sensory, and circulatory. We've been doing it all semester. It's just a new term for it. Prompt transport if there's any compromise in that distal circulation. Fractures of the forearm, you've done. Fractures of the hand. Think of somebody punching a wall. Guy gets mad and he punches the wall, and he found that stud he could never find when he was hanging stuff for his wife, but when the Cowboys lost again, he punched the wall and he found the stud. And that fifth metacarpal is usually so find your pinky finger and find that knob, that condyle on the wrist, and halfway between those, that fifth metacarpal, that is where a boxer's fracture happens. How do we treat that? Put ice on it and transport them. Okay. Pelvic fractures we've talked about. High velocity injury, assess for any injury to the bladder, like as we've already discussed. So we're palpating for lower abdominal tenderness. We're asking questions about any hematuria, blood in the urine. So that's what you've been doing this semester. We teach you to squeeze at a different place, don't we? We teach you to go down here to the greater trochanter and push in. Pre-hospital trauma life support goes to the greater trochanters and pushes in, and this book is behind and still goes up there to the iliac crest. You could also, maybe it doesn't elicit that much of a painful response when you compress in at the iliac crest, but you go ahead and palpate down there in the pelvis. You're feeling to see if you find rigidity there where the bladder normally is, and you're palpating, you start to palpate, and that elicits pain. I don't ever want to see you take the heel of your hand and push down on the pubic symphysis. That's the old way. Really, you shouldn't be doing the middle one, but you definitely don't push down on that pubic symphysis. You could take a stable pelvic fracture, destabilize it, and lacerate. You could puncture the bladder. You could lacerate femoral artery or femoral vein that come right down that oblique angle that I'm making with my mouse. Do not do that ever. All right. Remember this acronym, BODI, for injuries of the hip, break out, dislocate, end. So if the limb is shortened and the foot is externally rotated, meaning the toes are pointing to the outside and the limb is shortened and there is pain around that area of the greater trochanter there where I showed you where that femoral head is, that actually is what breaks off in a hip fracture, or that is what we call a hip fracture. So the break out, if it's shortened and externally rotated, in all likelihood, you're dealing with a hip fracture, proximal femur fracture. If the toes point to medially, then that is dislocate in the direction the toes point. So break out, the toes point outward, that we're going to treat that as if that's a hip fracture, proximal femur fracture. If the toes rotate and point to the midline, we're probably dealing with a hip dislocation. So the ODI is your acronym. Posterior dislocation of the hip is often going to involve the sciatic nerve, which is a very large nerve, and that causes lots of pain and lots of problems. Severe pain in the hip can have radiating pain down the leg, and absolutely they do not want you to try to move their hip. Don't attempt to dislocate, to reduce any dislocated hip in the field. Splint the dislocation. In the position you find it, you're probably going to be splinting them to a long spine board. You can support the affected limb with pillows. That the hip fracture, the break out, sometimes you can put a pelvic binder on there and kind of relieve some of that pain. The problem is if you move that around very much, you can do more trauma. So contact medical control before you ever, and if your protocol says no, you don't do that. But contact medical control if you ever think you need to apply a pelvic binder to a fractured hip. Prompt transport. Proximal femur, been talking about that. Leg rotates out. Of course, we're going to assess motor, sensory, and circulatory. Going to splint the lower extremity, transport them to the hospital. You know how to manage femur fractures. We did it in lab with an isolated midshaft femur fracture. You're going to see that characteristic spasms quadricep, and that thigh humps up like you wouldn't believe. And also we treat that immediately as loss of 1 liter of blood. If there's no other trauma and it's clearly midshaft, we're going to use a trauma splint or traction splint just like we did in lab. Otherwise, we can't use a traction splint. Risk from that midshaft femur fracture would be laceration of vessels and damage to nerves. That's why you apply the traction splint to stabilize it. That's why the traction splint helps considerably with the pain. You just aren't going to use it very often as an EMT or a paramedic. It's just not that often that you find an isolated midshaft femur fracture and have a stable patient. 3 things that we have to use it, right? Injuries to ligaments. Ligaments connect bone to bone, and ligaments can be stretched, they can be torn. You'll see swelling, occasionally ecchymosis, point tenderness at the site of the injury, and we're going to splint all of those suspected knee ligament injuries with a rigid splint and put gauze in any voids to help support and stabilize that. The goal is for it not to move. Knee dislocation can compress the popliteal artery and stop blood flow to the distal leg and the foot. That's a right now emergency that needs to be fixed so we can restore circulation. Prompt transport and apply ice, and that's what we can do. Remember, we can't, even if it's the femur that's involved, if we have a fracture around the knee, that's contraindicated. Why is the traction splint contraindicated? The fracture is not midshaft of the femur, right? Okay, I already talked about dislocated patella. If it remains displaced, it hasn't been reduced, they haven't spontaneously reduced that, when you get there, you're going to splint that in the position in which you find it, knowing the whole time that if you could just straighten their leg out, it'd be fixed. Don't do it, though. If there's a circulation issue, which I can't imagine that there ever would be, contact medical control and ask for their advice. Ankle injury. The best splint in the world for an ankle injury is a pillow taped around the leg, around the foot and ankle, leaving a place so that you can still check cap refill and pulses and still touch a toe for the sensory portion of motor, sensory, and circulatory. It works great. It needs to be x-rayed and evaluated. Any open wounds, dress them. Assess motor, sensory, and circulatory. Again, that's distal neurovascular function. If there's a circulation problem and we had to try to reduce that to deal with gross deformity, and gentle traction is how you do that. Don't do that without calling medical control, please. Before you release traction, tape that pillow around that foot. That's the best one. I guess you could use a blanket. A pillow works better because it conforms and does a great job of stabilizing it. Foot injuries, this dude jumped off this wall and he landed on his heels. He could have a calcaneus fracture. He could have a tibia fracture. He could have a femur fracture. Could have dislocated his hip maybe. But look how that force translates up that lower extremity. And now, dadgummit, quit that. And now that's involving his lumbar spine, right? So spinal immobilization is indicated. Always, again, assess motor, sensory, and circulatory. We're assessing gross motor. Can they wiggle their toes a little bit? Can they wiggle their fingers a little bit? Fingers, they should be able to wiggle because we're talking foot injuries right now. I'm trying to rush and throw too many things together. That pillow splint, man, it's great. Air splint, it's okay. I don't see those used near as much as you used to. A vacuum splint, you don't see those used that much. They're expensive, and you may never get them back. Once you take them to the hospital, they might cut the dang thing off. Orthopedic surgeons tend to be in a hurry because time is money, and maybe they don't want to take time to deflate that thing, or they just cut it and get it out of the way. It's not their problem. Not your problem either. If that's what you use, don't be thinking, I might not ever get this back. If that's what you have, that's what you use. You splint that leg, it's a problem for down the road to get it back or replace it, all right? Remember RICEs, rest, ice, compression, elevation, splinting. Rest is obvious, stay off of it. Ice to reduce swelling and pain. Compression, that's that applying an elastic wrap. That compression, that relieves a lot of pain, I promise you. Elevation, that's to deal with swelling. Splinting, that's to avoid movement, which causes pain and which can cause further damage. That's RICEs, that's why we do it. It's obvious what we're talking about from each of the 5 fingers of that. Okay, amputations I've talked about. Let's go through the treatment again. Immobilize the part what's the portion of the limb that's left. Let's immobilize that and not move it around. And we put bulky compression dressings on, and sterile, let me add that, sterile bulky compression dressings around the stump, the part that's still on their body. My idea would, and I've done this and I think it works great, you can take a multi-trauma dressing, maintain sterility of that, cup that around that stump, and then you can take an elastic bandage, normally called an ACE wrap, and you kind of cross that back and forth around that stump end and coming up on to the proximal part of that extremity, so it kind of provides an anchor, and that will do a good job of several things. That we've already irrigated it out to get any dirt and stuff like that out, but that is going to help keep that clean and hold that in place, and it's going to provide some direct pressure on that stump to deal with localized bleeding. If bleeding is severe, throw a tourniquet on it, then quickly provide those steps that I just went through. The amputated part, what do we do with it if we can find it? Wrap it in a clean, sterile dressing, place it in a plastic bag. Know where the plastic bags are on your ambulance. If there aren't any, ask them to buy some. If they won't buy some, go to the dollar store and buy like 3 different sizes of plastic bags. Roll those suckers up and keep them in with your personal gear that you haul in the ambulance, and you can always pull one of your little bags out and use that, knowing that you'll never get it back, nor do you want it back. All right. Your local protocols may have some additions to this. Now that we have sterile gauze wrapped around the amputated part, and we have it zipped up in a Ziploc baggie so that it is tight sealed, then we can place that in an ice-filled container, or we can place it on chemical ice packs and transport that with us. Don't delay, excuse me, don't delay transport. While you're doing this, if you need to call for a second ambulance because you're dealing with life threats, and let them collect the severed part and manage it accordingly, then do that. That's additional resources. That engage those, utilize them. We're all there for the same thing. So what if you get the sexy part of hauling the multi-systems trauma patient to the hospital, and all they get to do is collect an arm or a hand and wrap it up? Maybe next time they'll be lucky and get to take the patient. It might be less paperwork if you're bringing the hand to the hospital, and don't worry about transporting a severed head. As a joke, I started to say always looking to get ahead in life, but we don't tend to take those with us. Okay, compartment syndrome, and then we will be wrapped up here. Compartment syndrome, muscle is covered with fascia. That muscle fascia forms a capsule. And if there's excessive bleeding following musculoskeletal trauma, it bleeds into that capsule. You see this a lot of times in a crush injury. You can see it other times, but it bleeds into that capsule. And remember, we talked about the liver being in a capsule, and eventually it hits the point that there's nowhere to go because that capsule's too tight. That can happen with a crush injury to an arm. We're just going to use a radius and ulna crush injury in a machine and welding shop, and that causes bleeding. And that, especially if it's arterial bleeding, it bleeds until that capsule can't expand anymore, and so it can't expand outward, so it puts pressure inward, and eventually it starts to compress arteries. And when you compress arteries, you now have an ischemic limb. It's just like having a tourniquet on it. No blood flow past where that constriction is in that compartment. Usually this is a delayed injury. You see this develop later, so we don't see it that often. Pre-hospitally, patients usually already transported, or maybe they self-transported. So how do we know when this thing exists, right? Because we might want to know how, when I find a patient with this, I'm the lucky guy who gets the long straw and I get to see it and treat it, because that's how we think. We're the lucky one when our patient's the unlucky one. That's why we go in this business. It's okay to feel that way. You're not abnormal. That's the way we all are in this business. If it's going to happen, I want to be there to see it and treat it and tell the war story later without breaching HIPAA. All right. That becomes problematic too, doesn't it? Okay, you have pain that is out of proportion to the injury. Maybe this is just a blow with a helmet to the forearm, and it causes bleeding within that capsule around that muscle, but it's a slow bleed, but it keeps on bleeding, and you see that contusion on the arm, but they're screaming, they're in horrendous pain, and you're thinking, my gosh, you just got a bruise on your arm. What in the heck? Well, when that pain, there's two possibilities. Your patient's a wuss. Okay, move that one aside. If that pain is out of proportion to the injury, let that trigger in your head. Oh yeah, the old fat bald guy said something about compartment syndrome, and that's because of that swelling and stretching of muscle tissue within that capsule that restricts and eventually stops blood flow. So you have pallor or paleness distal to that, decreased distal sensation, and you ask them to wiggle their fingers and they can just barely move them. Oh man, I remember Buddy told me about these things. I think I'm seeing compartment syndrome. What I do, rapid transport, possibly call for ALS, ice it, contact medical control, get them to the hospital like right now. They will, in all likelihood, need a fasciotomy. What is that? They take, I'm talking a forearm now, so doctor takes a scalpel and slices through through the skin and down through that capsule, that fascia that surrounds that muscle. And once that fascia is open, hence the term fasciotomy, there is room for everything to swell, instantly restores, unless you have damage, unless you have a fracture that has damaged an artery. And once that capsule is open, once that fascia is open, then you instantly restore distal circulation, pain goes down, motor function increases, that hand or whatever the case is, it warms back up because perfusion is restored and everybody starts to get happy again. Google fasciotomy and you see some cool pictures. If you think your patient has compartment syndrome, splint the affected limb, keeping it at the level of the heart. That cuts down on the amount of blood pooling within that capsule formed by that fascia, and that's going to help stop the further progression of compartment syndrome. I'm talking emergency return. What if I get to the hospital and it wasn't compartment syndrome and I ran them in lights and sirens and I told everybody in the world I just saw compartment syndrome and then it didn't? That's okay. We're operating with almost blindfolded out there. We don't have x-rays. We don't have Dopplers to assess blood flow through arteries. We don't have any of that stuff. We are doing the best we can with the clinical tools that we have. And if we're occasionally wrong and we erred on the side of caution, we haven't heard a thing. Only thing we did is slightly increase, or well, maybe more than slightly, we increased the risk of a motor vehicle collision between point A and point B while we had lights and sirens going. That's this business. That's one of the downsides, one of the risks of this business that we all assume to one degree or another when we become a first responder. All right, and that is it. If you have questions, either call me or either shoot me a text or an email. I've got a bunch of stuff I've got to do, and I won't probably be available to answer a phone call. So if anything comes up, let me know. And then I will see you at the beginning of your all-day Saturday class. And then I will turn you over to William Riley to do with you as he sees fit, meaning educate you on scene operations, extrication, and all that stuff, which that man could lecture in his sleep. You're getting one of the three best in this whole part of the world and I won't tell you which one's number one because it's just whoever's covering this all-day Saturday lecture for me. That's number one. But I put Riley up against anybody, anywhere for fire or EMS work. So don't tell him I said that. He'll think I like him. All right. Stopping the recording now, ending the lecture. See you guys Saturday morning.